Good afternoon. Welcome to today's webcast entitled Planes, Pilots, and Preterm Labor, the Role of Protocols and Standardization in Patient Evaluation. Presented by Dr. Michael Ruma, Maternal Fetal Medicine Specialist, Perinatal Associates of New Mexico, Albuquerque, New Mexico. Following the talk, we'll have a short question and answer session. You can ask questions at any time during the presentation via the web using your Ask a Question box. If you should need technical assistance, type your inquiry into the tech support box on the left side of your screen and click the Send button. If you are disconnected, you can log on again using the instructions provided to you for accessing this webcast. If you cannot log back on, please call 877-843-9272. It is now my pleasure to turn the webcast over to your speaker, Dr. Ruma.
Thank you very much for that nice introduction. To start, I'd like to thank Hologic for the opportunity to speak to you today. And on their behalf, I would like to thank each of you, the attendees, for taking time out of your busy schedules and your investment in taking a moment to spend with us on this webinar. I'm very excited to spend the time with you today and to talk to you about planes, pilots, and preterm labor, the role of protocols and standardization in patient evaluation. Over the next 30 minutes, I'm going to provide an overview of evidence-based research supporting our current means of evaluating the patient with preterm labor symptoms. And then I'm going to introduce the importance of protocol-based evaluation and standardization and detail at least one example, primarily in the airline industry, of how protocols have been successful. I will then present an example of a protocol developed specifically for the patient with preterm labor symptoms, focusing on its cost effectiveness, safety, and how it was integrated into their system. And hopefully, by the end of our discussion today, I'll have been able to stimulate at least some of you to delve further into your own research on how you might develop and implement a protocol within your own institution. And at the end, we're going to conclude with a question and answer session to discuss some of your thoughts. Before we get too far, though, I would like to disclose that I am a member of the Hologic Speakers Bureau and a paid consultant for Hologic, who's bringing this educational activity to you today. In order to learn a little bit about our audience, I'd like to go through a few brief polling questions which you can answer online as we go. So first off, what best describes your current role? Now, it looks like we have about 10-20% of us are physicians on the webinar today. 60-some% are nursing staff or nurse midwives, and then a few folks that would fit into other categories. Question number 2. How often do you utilize fetal fibronectin or FFN testing for patients with threatened preterm labor less than 34 weeks gestation? Never, a fourth, a half, 3/4 of the time, or all of the time? It looks like about 50% of you use fetal fibronectin testing in all evaluations, and then a smattering of the rest of the time. Question number 3, how often do you utilize cervical length evaluation for patients with threatened preterm labor less than 34 weeks gestation? And again, similar time frames, never, a fourth, half, 3/4, or all of the time. And it looks like about 25% of, or about 30 to 40% of us use it a fourth of the time, 25 or fourth of us use it about half of the time, and a very small portion completes a cervical length in every evaluation. And our last polling question, does your facility or medical practice have an established protocol for the evaluation of patients with threatened preterm labor? Yes, we have a protocol. No, but we're thinking or planning on implementing one. No, I don't plan on implementing a protocol. So again, it looks like about 30% already have an established protocol, and the rest of you, the majority of the rest of you, do not have a protocol but hope or are planning on implementing one. So that concludes our polling questions. This photograph is from 1935. It was taken at Wright-Patterson Airfield in Dayton, Ohio, and is where the U.S. Army was holding a flight competition in order to provide competitive bids on the next generation of long-range bombers. And Boeing, of all of the aircraft manufacturers present that day, was already assumed to be the winner because they showed up with a brand new aluminum alloy plane that could carry 5 times as many bombs and fly twice as far as the Army had requested specs for. The Army was on the line to purchase at least 60 more of the winning aircraft, so this was a very large contract and an important one at the time. Boeing's entry was dubbed the Flying Fortress, primarily because of its size. So on that historic day in October, as all of the Boeing executives and the Army brass sat and watched, Boeing's brand new 103-foot wingspan plane with 4 engines, 2 more than any other bomber of its kind in the day, began to taxi down the runway, took off and climbed to around 300 feet, stalled, and then came crashing into the ground, killing 2 of the 5 crew members on board, including Boeing's primary test pilot, Major Peter Hill, for whom this airfield is named today. Now, this new plane had tons of new features, and after the crash, newspapers reported that the B-17 was just too much plane for one man, one human, one pilot to fly. Maybe the plane needed more pilots. Maybe the plane and the pilots needed more training. Well, interestingly, that really was not the fact. After the crash, a lengthy investigation was undertaken, and the investigators found that there was absolutely nothing mechanically wrong with the aircraft. What they found was that it was simply pilot or human error. And the crash investigation found that the pilots, in their normal activities of the day, had neglected to check the movement of the flaps on the wing. And their failure to remove a small metallic clip that was used to protect the flap while the plane was on the ground ultimately led to the crash and their demise. Now, this is where Boeing was absolutely brilliant in defeat. They didn't scrap their new plane. They didn't simplify their newly designed advanced aircraft. In fact, the only thing that Boeing did to successfully allow humans, pilots, to fly the B-17 was develop something called the pre-flight checklist. Now, keep in mind that even in 1935, asking a pilot to utilize a checklist like this would be like me asking you to utilize a back the car out of the driveway checklist, or maybe a preterm labor evaluation checklist in triage. No good pilot would ever use one. Why should they? They knew how to fly. The reason is that it worked and led to a huge reduction in error and a substantial improvement in outcomes. With the pre-flight checklist in use, the Army ended up buying over 13,000 of these aircraft, which were previously deemed too much of a plane for one man to fly. And thus, the Boeing B-17 Flying Fortress became one of the most successful planes in history and was instrumental in the Second World War, logging over 1.8 million combat flights without a single incident related to human error again. So what might have been on that pre-flight checklist? Well, relatively dumb stuff like flip this switch and then check this gauge and then close the window, release the brakes, take off the metal clip off of the wing flap. Not a single item on the checklist was particularly difficult or beyond what pilots thought that they did every day and on every flight. But because of the development of the pre-flight checklist and its huge impact, not a single military, commercial, or private aircraft flight takes off today without either the pilot and or co-pilot going through this pre-flight checklist, as dumb as it might sound. Why? Because even simple mistakes and oversights can have a very large impact, like the crash of the first Boeing B-17. So parallels have been drawn between the airline industry and medicine and our need for implementation of similar checklist-based protocols. And in medicine, we've adopted some of these in a few areas of our field. One such example is in the operating room, where we commonly use timeout procedures to identify the proper patient, to discuss the procedure we're doing, to make sure everyone has in the room what they need, and quite simply to make sure we're operating on the correct side of the patient. In other areas, though, in medicine, and in my opinion in obstetrics, we're particularly slow in adopting and approving protocols in medicine and utilizing these checklists to improve our outcomes. And one such area is, in my opinion, in the evaluation of the patient that presents with preterm labor symptoms. So let's change gears a moment and move away from planes and pilots and talk about what we do each day as obstetricians, midwives, labor and delivery nurses, or other providers, regardless of what path you're on in taking care of patients. How do we evaluate patients who present with threatened preterm labor? What exactly are the components we might use to come up with our own checklist, similar to how Boeing came up with their pre-flight checklist to improve their outcomes? We know there are a variety of ways to assess and evaluate pregnant women with preterm labor symptoms. We can take a very good detailed history, evaluate for risk factors such as a prior spontaneous preterm birth. We can talk to the patient about contractions and symptoms such as vaginal bleeding. We can examine the patient using a routine digital cervical examination. We could complete a transvaginal ultrasound to obtain a cervical length, or we could collect a fetal fibronectin swab and conduct that testing. These are all tools available to us, or in pilot terms are the switches and the procedures that we have in our cockpit. The question, though, is how do we use them, in what order do we put them, so that we can achieve the best outcomes in our field. So a variety of studies have looked at the predictive ability of these tools to predict delivery prior to a certain gestational age in weeks, and this is one example that looks at the likelihood of preterm delivery prior to 32 weeks from Goldenberg. And you can see that each tool performs differently in its predictive ability for true preterm delivery. If patients present with uterine contractions, takes their baseline risk and increases their baseline risk by a relative risk of almost 2. If they have an obstetrical history of prior preterm birth, it increases their baseline risk to over 6. If they, say, have a fetal fibronectin that is positive, their risk is almost 14 times greater than when they walked in previous to that presentation. Other studies have attempted to quantify the efficacy of these tools by determining the likelihood of preterm delivery within a certain number of days from the actual evaluation. And again, you can see that each tool, or a combination of these tools, performs differently and better for the prediction of preterm birth. And for example, if we take patients that have contractions as they present to triage, their predictive ability of that tool for delivery within 7 days is about 10% of those patients will deliver. If we look at patients with short cervix, over 10% of those patients will deliver within 7 days. And if we have a positive fetal fibronectin and a short cervix, that a recent article, systematic review by DeFranco, that's going to be published in the Gray Journal, in the American Journal of Obstetrics and Gynecology in this year, says that short cervix and a positive fetal fibronectin has a positive predictive value of over 40% for patients that will deliver preterm within 7 days from your evaluation. So with these tools, we then have to decide on a variety of next steps in the care of our patient. We can use these tools and decide, do we need to admit the patient? Do we need to transport the mother to a higher level of care by either ambulance, helicopter, or fixed-wing aircraft? Should we administer medications to them, such as antenatal corticosteroids? Should we tocalize the patient? Or maybe we use these tools to provide recommendations in regards to modifications of their activity or their lifestyle. As you know, all of the interventions have a cost in dollars. The average hospital admission for a maternal patient for 48 hours is around $4,200. If you need to transport a patient, particularly by helicopter, MSNBC, a recent article, says that costs in the realm of $12,000 to $25,000 for a medical helicopter transport. If we don't intervene appropriately, there's a cost as well. And primarily, the preterm infant is who suffers those consequences. This is a trial that was done in Canada by Chen looking at outcomes of preterm infants delivered in what they called inborn versus outborn facilities, but is really inborn are large or tertiary medical centers, with outborn being secondary or lower level hospitals with limited neonatal intensive care unit capabilities. And you can see if we don't utilize our tools correctly, we may fail to identify patients and fail to transport appropriate patients and ultimately cause harm to our preterm infants. You can see that the death rate in the neonatal intensive care unit, if born in a facility that's not capable of caring for them, is almost twice as high as if that infant was born in a tertiary level medical center. And their rates of medical complications are also as high. So acknowledging the tools, our available interventions, and understanding some of the costs of intervening and not intervening correctly, how exactly do you evaluate the patient with threatened preterm labor in your own facility? My guess is that your facility, similar to mine, has a haphazard approach. And this is related to a variety of reasons. We have significant autonomy and differences between providers. Our field has a lack of oversight and a lack of enforcement in order to encourage us to do the correct thing. We all have different training and different personal medical training experiences. Our levels of concern are different. And unfortunately, in all fields of medicine, there's always conflicting research. And in particular, in preterm labor evaluation in our field, there ultimately is no established standard of care for how this should be done today. But just as the airline industry is overseen by the Federal Aviation Administration, just like pilots, if you're an obstetrician gynecologist, we're overseen by ACOG, the American College of Obstetricians and Gynecologists. And our professional organization, ACOG, is calling out to us, healthcare providers, to do a better job by standardizing our practice. And what ACOG's calling us to do is to develop protocols and checklists because they've been shown to reduce patient harm through standardization. The development of protocols, though, may be contentious, but they do improve outcomes by performing tasks the same way every time, ultimately reducing the rate of human error. And ACOG calls upon physicians to take the lead on the development of these protocols, because otherwise external sources may impose requirements that we don't particularly approve of. ACOG says that the process of development of protocols should be collaborative, inclusive, multidisciplinary. It should include hospital administration, all types of healthcare providers, including nursing and support staff. And then ultimately, when a protocol is developed, we should notify and train all of the personnel who are going to utilize the protocol. And with hope, we'd have an arm that would allow us to collect a certain amount of data so that we can review our protocol implementation and see if it's improving outcomes. So since we're being called to design a protocol in order to do a better job, what exactly would it look like? What tools would we like to implement and utilize? Well, fortunately, we don't have to design our own from scratch, because researchers have been proposing protocols for the evaluation of patients with preterm labor symptoms for over a decade. And these are just 3 examples in order to provide you a little bit of information where you might start your own protocol development. And I'm not going to spend a great amount of time going over these. You can reach out to IMES in the Green Journal in 2003 or the March of Dimes Preterm Labor Assessment Toolkit, which was published in 2006, and review these. But these exist as examples of previously published protocols in the literature. If we were going to establish and implement a protocol in our own institution, what would we think are the potential benefits? If the patient went through the entire protocol and had a negative evaluation, ultimately it should lead to decreased maternal admissions, a decreased length of stay. We should avoid maternal transport. It would hopefully be cost-saving to the patient and to the healthcare system. And most likely, hopefully, it would provide emotional and social benefits for the patient. If the patient, through this protocol evaluation, had a positive evaluation, we as the healthcare provider would then be able to specifically target intervention to that patient at greatest risk for preterm delivery. So is there evidence to support all of this effort? Is there evidence that shows that protocol and implementation of tools such as the ones we've covered actually do anything to hospital admissions, length of stay, expenditures in healthcare system, and in patient outcomes? Well, again, for the sake of time, I'm not going to go over all of this specific research, but I would like to provide this article by Duda, published in 2010, as a resource for you to review that provides a great amount of information on all of the articles published that detail support of implementation of these tools in protocols for reduction of admission, length of stay in patients that have undergone a preterm labor symptom evaluation. Duda also goes on and talks about implementation of fetal fibronectin testing in a protocol, and it is truly cost effective. And all of these articles, or the majority, present that FFN use in a protocol can reduce costs in the healthcare field. There's also substantial evidence, there's at least 5 trials, including this as an additional trial, that show that utilizing cervical length assessment by ultrasound and FFN together in a protocol can have a very large impact on hospital admissions, length of stay, and cost. And this article by Rose, Cost-Effective Standardization of Preterm Labor Evaluation, demonstrates this very well, and I'd like to spend a little bit of time reviewing that with us next. So this is their standardized protocol that in 2010 was implemented at the Mayo Clinic, and patients ultimately over the year went through, they had their gestational age assessed, uterine contraction activity was confirmed, all patients underwent a speculum examination obtaining gonorrhea and chlamydia cultures, group B strep cultures, and a fetal fibronectin swab was obtained. A digital cervical examination was then performed. If the patient was 3 centimeters or greater dilated or significantly effaced, they were immediately admitted and treated for suspected high risk for preterm delivery. Or if they were not significantly dilated or effaced, they underwent a transvaginal ultrasound assessment, and then depending on how short the cervix was, they received different treatment and were either discharged or ultimately admitted for observation and administration of steroids. The study looked at over 200 patients. About 24 of these patients, or 17% of them, delivered preterm. The authors felt that their protocol performed very well with an extremely high negative predictive value at both 7 and 14 days. And importantly, the takeaway is that this study demonstrates, in comparison to the year previous where the Mayo Clinic did not have an established protocol, this year in 2010, they were able to reduce their maternal admission rate by over 50%. And their estimate, conservative estimate, on cost savings was around $40,000. Ultimately, they felt that the protocol was a success and it became a formal departmental policy at their institution. Rose and the other authors go on to discuss in their article that if this protocol were to be extrapolated and taken and implemented on a national scale, assuming about 4.2 million births in the United States per year, and about 9 to 10% of those patients requiring an evaluation or an admission for preterm labor symptoms, that if applied nationally, would save over $500 million from decreased maternal hospitalization. Now, this is one example. It's a very recent example, the Rose trial, but there is always future data that we as healthcare providers need to assess, and I'd like to provide you a couple sources of additional information to pay attention to. One trial by Chow that's listed in clinicaltrials.gov is going to look at whether or not the traditional approach of preterm labor evaluation utilizing serial digital examination of the cervix is better or worse than an algorithm or protocol-based approach utilizing both vaginal ultrasound cervical length assessment and fetal fibronectin collection. And this is proposed on the site, is still listed as being completed in August of this year. I reached out to Dr. Chow, but could not get any additional information, so we'll have to pay attention to the journals and the meeting presentations to see what the results of this trial are. There's another trial that's very interesting as well that demonstrates the significant potential of cervical length assessment by ultrasound and fetal fibronectin testing. This was performed by Dr. Wies in the Netherlands. And I sent him a quick email before putting these slides together, and he was nice enough to tell me that this presentation that was listed on the Netherlands Registry of Existing Studies was actually completed and is going to be presented tomorrow at the Society for Maternal Fetal Medicine annual meeting in San Francisco. And if you have time to pay attention to that, you should look to the concurrent oral session on prematurity. Abstract number 11 is going to detail that, in short, women with signs of preterm labor, that the optimal workup is cervical length measurement, fetal fibronectin testing, and a close evaluation of the cervical length and between 15 and 30 millimeters. Cervical length and FFN testing is very, very helpful in reducing unnecessary referrals and treatment in patients that present with preterm labor symptoms. I'd like to conclude. I do believe that there's a substantial amount of evidence-based data that supports the use of fetal fibronectin testing and cervical length evaluation for the patient with preterm labor symptoms. Standardized protocols for the evaluation of these types of patients have been shown by evidence and published research that it does indeed reduce hospital admission and healthcare costs. And like in all fields of medicine and all subjects in medicine and in obstetrics, future research will always continue to direct the development, our refinement, and how we implement protocols in the future. I'd like to conclude with a quick quote from Dr. Gawande from the Checklist Manifesto that I think sums up very well this topic. We're obsessed in medicine with having great components, the best drugs, the best devices, the best specialists, but we pay little attention to how to make them fit together well. Before we take questions, I want to review a couple polling questions today. To conclude, does today's presentation provide enough information to consider the utility of a protocol-based evaluation for patients with threatened preterm labor? A, yes, B, no, or C, I'm not sure. And you guys are being very kind and say that we're relatively convincing today that you think that we should think about a protocol in this field of obstetrics. And our last question, what additional information do you need to initiate a protocol-based evaluation for patients with threatened preterm labor? Do you want randomized controlled trial data? Do you think a practice bulletin recommendation from the American College of Obstetricians and Gynecologists is helpful? Is March of Dimes support important? Do you need to conduct your own review of the literature in order to make an ascertainment of the utilization of this, or do you not need no additional information? And it looks like about 40% or so need a randomized trial, and the rest of you would like to review the literature yourself. I'd like to thank you for your time. I really appreciate the opportunity to come and chat with you today, and I'd be happy to take any questions. We have one question, it looks like here. Is it feasible to expect all institutions to have 24-hour capability to perform transvaginal ultrasound cervical length? Well, this is a very good question, and a question that each institution will have to address individually. I work in New Mexico, and there are rural locations and several tertiary level hospitals, all of which are going to have different capabilities to assess this. Optimally, the evaluation of a patient with preterm labor symptoms would include both vaginal cervical length assessment and fetal fibronectin assessment. But if that's not able to be obtained, utilizing a very predictive tool such as fetal fibronectin, and is widely available in the United States today, would be most likely a second best approach. And hopefully in any future published protocols, this will be included, that if cervical length evaluation is unavailable, fetal fibronectin testing should be undertaken because it has the next highest predictive ability, both negative and positive, for what that patient is likely to do as far as are they going to deliver preterm or not. I have another question. In your practice, how do you collect fetal fibronectin swabs for patients with threatened preterm labor symptoms? This is a good question because people often think about whether or not it's capable to, or we can collect fetal fibronectin swabs blindly, or do we need to collect them with a speculum examination. In my practice, I personally think that for a patient that's truly presenting with preterm labor symptoms, it's best to perform an old-fashioned speculum examination. It will provide you a great amount of information visually about what the cervix is doing, allows you to cautiously and carefully obtain all of your cultures, and takes really nothing significantly greater than 1 to 2 minutes of your time, and I do think that that's the best approach. Another question is, how do you time administration of antenatal corticosteroids in your practice? In my practice, I think that the greatest benefit of antenatal corticosteroids, particularly in reducing the rate of respiratory distress syndrome in preterm infants, is if that is given within 7 days of administration. And ultimately, as we've reviewed in this talk, there are a lot of different tools that we can utilize. We can talk to the patient, we can examine the patient, we can use fetal fibronectin testing, we can use cervical length assessment. But ultimately, using all of them is going to provide you with the most information and the greatest predictive ability of the patient who's actually going to deliver within 7 days. And so personally, I try to utilize all of these tools in order to time steroids appropriately. And that looks like one more question. Sorry about that. Are there other ways to determine cervical length besides ultrasound? people have compared in studies utilizing digital examination, utilizing other tools to measure the cervix. Personally, I think that utilizing ultrasound is typically readily available in most modern day facilities, and I do believe that utilizing transvaginal ultrasound assessment of the cervix with an ultrasound machine is truly the best way to go about getting that information. Well, those are all of the questions we have today. Again, I'd like to thank you very much for your time, and we look forward to seeing you next time. Thank you so much.